Slipped capital femoral epiphysis is an orthopedic disease condition what this picture shows that X-ray findings AP view frog leg. Look at this. Then MRI detect early or pre-slip cases. Then CT scan. Look at this. Use if complex anatomy or surgical planning is needed. A detail going on. Introduction. Slipped capital femoral epiphysis is one of the most common hip disorders in adolescents involving the displacement of the femoral head capital epiphysis related to the femoral neck through the growth plate. It is considered an orthopedic emergency because untreated slips can lead to long-term disability, osteoarthritis, and avascular necrosis of the femoral head. SCFE usually occurs during periods of rapid growth, especially in overweight adolescents or those with underlying endocrine disorders. Definition: slipped capital femoral epiphysis (SCFE) is a condition in which the proximal femoral epiphysis slips posteriorly and inferiorly relative to the femoral neck at the growth plate without displacement of the metaphysis. Etymology: epiphysis Greek epi upon physis growth referring to growing end of the bone. Capital femoral meaning the head of the femur and slipped describing the displacement of this head from its normal position. Epidemiology: SCFA affects approximately 2 to 10 per 100,000 children annually, most commonly between age 10 to 16, with a male predominance. It is more frequent in overweight adolescents and has higher prevalence among African American, Pacific Islander, and Hispanic populations. Types: SCFE can be classified by duration, severity, and stability. A. By duration. 1. Acute. Symptoms present for less than 3 weeks. Sudden onset, often after trauma. 2. Chronic. Symptoms present for more than 3 weeks. Gradual onset with intermittent pain. 3. Acute on chronic. Chronic symptoms with sudden worsening due to additional sleep. B. By stability. Load or classification. 1. Stable SCFE. Patient can bear weight with or without crutches. 2. Unstable SCFE. Patient cannot bear weight. Higher risk of avascular necrosis. C. By severity. Southwick angle on X-ray. 1. Mild less than 30 degree. 2. Moderate 30 to 50 degree. 3. Severe more than 50 degree. Causes. SCFE results from medical and biological factors that weaken the growth plate, allowing slippage. 1. Mechanical stress from rapid growth and increased body weight. 3. Weakness of physis due to hormonal changes during puberty. 4. Endocrine abnormalities. Example, hypothyroidism, growth hormone deficiency, hyperparathyroidism. 5. Microtrauma or acute trauma to the hip. Risk factors. 1. Age, usually 10 to 16 years old. 2. Sex, more common in boys. 3. Obesity. 4. Rapid growth spurts. 5. Endocrine disorders. Hypothyroidism, pituitary disorders. 6. Family history of SCFE. 7. Ethnicity. Higher rates in African American, Pacific Islander and Hispanic population. 8. History of trauma to the hip. Complications if untreated or delayed in diagnosis. 1. Avascular necrosis of femoral head. 2. Chondrolysis, loss of articular cartilage. 3. Leg length disturbance. 4. Hip osteoarthritis in early adulthood. 5. Chronic pain and limited mobility. 6. Deformity of hip joint. Pathophysiology, step by step. Brief. SCFE is mechanical failure through a weakened proximal femoral physis during adolescence. Below is a clear ordered sequence from predisposition to long-term consequences. 1. Predisposition, systemic change, pubertal hormonal changes, growth hormone, sex, steroids, thyroid axis abnormalities, obesity, alter physical biology and weaken the growth plate, physis, especially the hypertrophic zone of the cartilage columns. 2. Anatomic vulnerability of physis. The physis is organized into reserve, proliferate, hypertrophic zones. The hypertrophic zones is mechanically weakest and therefore the usual site of the slip. 3. Increased mechanical load or shear stress, rapid growth, increased body mass and hip shear, sports, twisting, place high shear forces across the proximal femoral physis. 4. Microfailure of physial cartilage causes micro tears and disruption of the columnar chondrocyte architecture in the hypertrophic zone, producing physial widening and the start of displacement. 5. Microscopic slippage. The femoral metaphysis moves anteriorly and superiorly related to the epiphysis clinically described and posterior inferior slip of the epiphysis related to the neck because the epiphysis remains in the acetabulum. This produces the characteristics external rotation, posture and loss of internal rotation. 6. Progression pattern, chronic versus acute. 1. Chronic, slow progressive displacement with adaptive remodeling of soft tissue and slow deformity development. 2. Acute, unstable, sudden large displacement often after minor trauma with little time of adaptation and higher complication risk. 7. Physical healing or persistent instability. It stabilized fibrous tissues and bone bridge may form and the physis closes. If not stabilized, the slip can progress, increasing of deformity. 8. Vascular injury and risk. Avascular necrosis. Slippage and displacement can stretch, kink, or tear the articular vessels, mainly branches of the medial femoral circumflex artery that supply the femoral head. This is most likely in unstable acute sleeps and can lead to avian. 9. Cartilage injury and chondrolysis. Mechanical abnormalities and possible intra-articular inflammation can provoke cartilage loss and synovitis, causing rapid joint space narrowing and pain. 10. Altered hip biomechanics. Femoroacetabular impingement FAI. The changed head to neck relationship produces abnormal contact with the acetabular rim during motion, causing pain, limited internal rotation, labral damage, and progressive osteoarthritis. 11. Growth and morphological sequelae, premature facial closure, remodeling, and mallunated geometry can cause leg length discrepancy, altered neck soft angle, and long-term gait dysfunction. 12. Clinical and radiographic correlates. The pathologic changes explain the common findings. Lymph, referred knee pain, limited internal rotation, positive cleanse line or posterior displacement on AP frog leg, lateral radiographies, and south beak angle used to quantify sleep severity. 13. Outcome determinants. Final prognosis depends on sleep stability and severity and on timelines of stabilization. Unstable and high grade sleep have the highest rate of AVN, chondrolysis, and early osteoarthritis. Signs and symptoms. 1. Hip, groin, thigh or knee pain. Knee pain is a common misleading symptom. 2. Limping. Widening gait. 3. External rotation of the affected leg. 4. Limited internal rotation, abduction and flexion of the hip. 5. Shortening of affected leg. 6. Out-toeing when walking. 7. Acute severe pain and inability to walk in unstable SCFE. Diagnosis. A. History and physical examination. Age, weight, duration of symptoms. Assessment of gait and hip range of motion. B. Imaging. 1. X-ray AP and frog leg lateral view. Best diagnostic tool shows posterior and inferior displacement of epiphysis. Cleanse line test on AP view, a line along the superior femoral neck should intersect part of the femoral head. If not, SCF is suspected. 2. MRI detects early or pre-slip cases if X-ray is negative but symptoms persist. 3. CT scan use if complex anatomy or surgical planning is needed. C. Laboratory test usually normal but endocrine workup If atypical, example, delayed puberty, bilateral slips. Nursing diagnosis. 1. Acute pain related to hip displacement and inflammation. 2. Impaired physical mobility related to musculoskeletal dysfunction. 3. Risk for impaired skin integrity due to immobility or traction. 3. Risk for infection related to surgical intervention. 5. Knowledge deficit regarding disease process and treatment. Medical management. 1. Immediate non-weight bearing on affected lymph. 2. Surgical fixation is the standard of care, usually in situ pining with single screw to prevent further slippage. 3. Prophylactic fixation of contralateral hip in high-risk patients. 4. Pain management with NSAIDs or acetaminophen. Nursing management. 1. Maintain strict bed rest until surgery. 2. Assist with positioning. Avoid internal rotation or excessive flexion of hip. 3. Provide crutches or wheelchair for mobility post operation. 4. Monitor neurovascular status of the affected lymph. 5. Educate patient and family on weight bearing restrictions and physiotherapy. 6. Monitor surgical suit for signs of infection. 7. Provide psychosocial support for adolescent adjustment. Treatment options. 1. In suit pining, gold standard screw is placed across the growth plate to hold the femoral head in position. 2. Open reduction to severe or unstable slips to realign the femoral head. 3. Osteotomy, corrective procedure for deformity. 4. Bilateral fixation prevents future slip on the other side in high risk cases. 5. Rehabilitation, gradual return to activity after healing. Psychosocial medicine. 1. Emotional support, address anxiety, depression or body image concerns, common in adolescents with mobility limitations. 2. Family education, teach parents about safer mobility, post-operative care and importance of follow-up. 3. Peer support group, encourage interaction with peers experiencing similar orthopedic issues. 4. School support, coordinate with teachers for home-based learning or modified activities during recovery. 5. Coping strategies. Teach relaxation techniques, guided imagery, or music therapy to manage pain and stress. Prevention. 1. Early detection at risk adolescents, especially overweight or with endocrine disorders. 2. Prompt evaluation of adolescents with unexplained hip or knee pain. 3. Weight management and healthy lifestyle in childhood. 4. Endocrine disorders screening and treatment. 5. Avoidance of excessive high impact activity during rapid growth phases in high risk individuals. In conclusion, slipped capital femoral epiphysis is a serious but treatable adolescent hip disorder that requires early recognition and urgent intervention to prevent long-term disability. A multidisciplinary approach including orthopedic surgery, nursing care, physiotherapy, and psychosocial support ensures optimal outcomes. Education and preventive screening play a vital role in reducing incidence and complications. Thank you. Have a nice day.